and welcome to Unstress. My name is Dr. Ron Ehrlich. Before we start, I'd like to acknowledge to the traditional owners of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and recognise their continuing connection to land, waters and culture. I pay my respects to their elders of the past, present and emerging. Well, today we are visiting sleep again, and unapologetically so. It's a timely reminder for us all, and I'm obviously very focused on sleep both professionally and personally, but I like to have a reminder on a regular basis as to just how important it is. And today's guest knows a great deal about this subject. Her name is Dr. Carmel Harrington, and Carmel is a researcher, a lecturer, an author, and an expert on sleep. Her wonderful book, A Complete Guide to a Good Night's Sleep, has been adorning my waiting room for many years, and it's a wonderful book that I would recommend to you all. She shares with us a personal story which I think you will find very confronting and very interesting. I won't spoil it for you. Look, I hope you enjoy this conversation I had with Dr. Carmel Harrington. Welcome to the show, Carmel.
Oh, thanks for having me, Ron. It's exciting to be here.
Thank you. Listen, Carmel, your journey has been an incredible one, really. We've been just touching on it before we came on air, but you've been a teacher, you've been a lawyer, you've done a PhD in sleep. Can you just run us through how that happened?
Why?
Why that happened?
Yeah, life is an interesting journey, and it often takes directions that you never anticipate as an 18-year-old, right? So when I first left school, as it was in those days many years ago, one of the careers for women was teaching. So, of course, I twaddled off to teaching and realised I didn't really enjoy education so much. So I decided to then specialise in my actual initial love, which is biochemistry. And I was a biochemist for quite a number of years. And then the realisation came that as a biochemist, you don't make much money. Especially in Australia, the sciences aren't paid very well at all. So I retrained as a lawyer, and I actually specialised in that area in medical law, which was really interesting. So I was using because it was clinical biochemistry I was doing. So that was really interesting, and I was quite happy in that. Unfortunately, at that point, my son died. I had 3 children. I had a toddler of about 2, and I had my son Alexander was about 4, and I had 2-year-old twins, or nearly 2-year-old twins, and Damien died one night, completely out of the blue, no reason whatsoever. And of course, it shatters you, and it takes ages to pick up the pieces. But it never made sense to me. How could a perfectly healthy toddler die one night? No explanation, nothing at all. And, I'd go and speak to whoever I could speak to, and they just would say, it's tragic, go home and have more babies. Well, that irritated the scientist in me incredibly. And so I started researching this area, and, it was really tragic. It was these days, we call it sudden infant death syndrome, but these days, because Damien was almost 2, it would be referred to as sudden unexplained death in childhood. Now, we think these deaths at this age of 2 is really, really rare. Well, it's not. It's just not talked about very much. And so the more I researched this, the more I kept thinking, we may not know what's wrong with these children. It's not obvious, clearly. But there's something fundamentally wrong to have such a catastrophic outcome, healthy 1 minute and dead the next. So as a biochemist, I became very interested in what was happening. Now, most of these deaths do occur in sleep, or that is presumed. They're all presumed to occur in sleep, but we're not 100% sure because no one's actually at the death scene. So the thing that looks after you in your sleep is your autonomic nervous system, and that's the nervous system that reacts, arouses you, makes sure that you breathe when you're meant to, make sure that your heart rate increases when it's meant to, etc., etc. So I actually gave up the law and decided to undertake study and do my PhD in the autonomic nervous system in infants. And so, of course, that was in sleep. So I had to learn all about sleep, which was a huge learning curve. In those days, we had these big machines that the pens would go all night, and you'd have a wad of paper this thick that you had to go through. And so you had to learn all about sleep. And then, of course, you had to, understand the autonomic nervous system. So I did my PhD. And, of course, the realities of life came back. By that time, I was a single mum. And I needed money to bring my children up and send them to school, like to educate them. The schools I wanted to send them to were expensive. So I went back to law. And at the same time, I was doing clinical work, but mostly I was doing law. And I was working again in sleep, and I was giving lots of lectures around sleep, but adult sleep more than infant sleep. And lots of people were so interested in it. It amazed me. I forgot that I didn't really know much about sleep before I started. And it amazed me how little people actually knew about sleep and how interested they were. And so one night after one of these lectures, and I was sort of traveling the world doing these talks, and someone said to me, well, what book can I read about this? It's absolutely fascinating. I said, well, there is no one book out there at the moment, but there's lots of papers. So I referred them to some academic journals. And of course, this person said, well, why don't you write the book? And that was the start of my more public life. And since then, of course, I've written 2 books, and I do a lot of work, both in the adult world of sleep, but also my research is still ongoing at the Children's Hospital at Westmead, and we're looking at the biochemistry now of the autonomic nervous system. And so it's going really well. It's a long journey, but, it's exciting, and, maybe we'll make a difference there.
Wow. I mean, this was, how long ago did Damien die?
30 years ago. Almost.
30 years ago. So this was, and my kids are of a similar age, this was something that we were hearing a lot about. Really, tell us a little bit about the condition as it was understood, as it is understood now. How common is it? What's the story about SIDS?
Look, you're right, Ron. Wasn't it something we were all scared of at that time? Because there was very little ability to monitor children. You just hoped against hope that it wouldn't happen to you. At the time when Damien died, it was more common than it is now. And just after his death, they had this back to sleep campaign where babies weren't being put on their tummy. You know how I think before a couple of years, about a decade before Damien was born, there was this push to put babies on their tummy, and you sort of slept them on their tummy. That changed because the incidence of sudden infant death was much higher in those babies that had been put to sleep in their last sleep on their tummy. So they did this back to sleep campaign, and now all babies are put to sleep on their back and were recommended not to put on their stomach. As a consequence, the rate of SIDS decreased dramatically. However, at the same time, we reorganised definitions. So SIDS now is strated. So there's sudden infant death in infancy, or SIDS, or sudden unexpected death in childhood. And there's a very thorough crime scene investigation, which it has to be. So as a consequence of that investigation and very strict guidelines on what can be called a SIDS, if a baby is found face down, then it's not called a SIDS anymore. It's called a sudden unexpected death in infancy, or SUDI, because they believe that this is an explanation for the death because the baby suffocated. Now, as a consequence of that, the figures look better when you look just at SIDS compared to if you look at the umbrella of sudden, if you put everything under the umbrella of sudden unexpected death in infancy, while the rate is much better, it's still not where you would like it to be. So basically, about 3 babies die every week in Australia.
Wow.
So that's every second day a family is going through the most unbelievable heartache that stays with them forever. And it breaks up families. It does all, So it is really tragic, and it's very much out there. And our understanding of it has improved remarkably. We know there's particular risk factors. For ease of understanding sudden infant death, there's a model that we use in research called the triple risk model. And so one of the aspects is a bit like all three things have to happen at one time. So we have to have a child at a particular age of maturity. So different things happen as children mature and their nervous system matures post-birth. So we have to have them in a particular vulnerable point of age. We have to have a certain risk factor in evidence. So it could be that the baby is laying face down. It could be that they have sleep apnea, which we've talked about in the past. It could be that they've got an upper respiratory tract infection, so it's making them vulnerable. But there also has to be a third component. There has to be an underlying vulnerability that is inherent in the child. And at the moment, while we know a lot about the maturation process, we know a lot about the risk factors, we know nothing about this third component, which is what is the inherent vulnerability that these children have that differentiates them from the rest of the population. And that's what we are honing in on at the Children's Hospital at the moment. And I feel very confident about what we're doing for the first time in 30 years, to be honest.
Wow. Well, then let's just unpick that, because my initial question, the one that comes off in my head, is what's on the short list of possibilities with that last one. But let's start with the age one. What is the age? I mean, is sudden unexplained infant death syndrome, does that occur at 6 weeks, at 8 weeks, at 12? When does that kick in as a possibility and end as a diagnosis?
Well, yeah, by definition, an infant is less than 12 months.
Mm-hmm.
All right, so sudden infant death can only occur in babies less than 12 months. So that's because that's their infant period.
Infants, yeah.
However, infancy doesn't start until 1 month. Before that period, you're referred to as a neonate.
Mm-hmm.
So definition-wise, sudden infant death is only recorded in babies from 4 weeks of age to 12 months of age.
Mm-hmm.
Right? If you stand outside of that and you're older, then it's called sudden unexpected death in childhood.
Yes.
Yeah, so most deaths, sudden death can occur at any time in your life. At any time in your life, okay? So we've all heard of the adult that just didn't wake up as well. However, most of the cases, in fact, I think from memory, I'm not 100% sure, 85% occur in the first 12 months of life. The next 10% occur in the first 2 years of life, and then the rest occur for the rest of their life. So at any time, people are vulnerable. But as you age, the likelihood or your vulnerability to sudden death decreases significantly. But indeed, your greatest period of risk is in the first 6 months of within birth. So, and interestingly enough, within the first 6 months of birth, you would think a baby would be born with a fully mature autonomic system, but they're not. Mm-hmm. There is growth and maturation of the autonomic system in that first 6 months. So it does leave a child most vulnerable in that period. I mean, there's other researchers you would talk to would talk about other theories, but me and my team, we're really focused on the autonomic nervous system. Yeah.
And neonatal reflexes is something that children are born with, and then as we mature as 12 to 18 months, 2 years, I think by about 2.5 to 3, most of those are they playing a role in this as well?
Well, a lot of people are looking at that as well, the reflexes. So for the first 4 weeks, we have quite amazing reflexes that are very protective, and they start to diminish after the neonatal period. And so people are looking at what effect the diminution of these reflexes are having on arousal, because basically one of the things that you can't get away from is that a child that dies must have faced a catastrophic event and has failed to respond to that catastrophic event. I mean, that's the basic fact. So mostly, as I would often say to people I work with or people I counsel, is if a baby is lying face down and it starts to increase their carbon dioxide and decrease their oxygen, their arousal mechanisms should kick in and they can move their head. Now, that's a very basic movement that all babies have. They can able to move their head or cry. They wake up. They don't. These children don't arouse to this challenge.
Mm-hmm. And then the second risk factor is the face down, the sleep. Face down is such an interesting one, isn't it? Because I think, if I'm not mistaken, Dr. Spock may have played a little part in this because of his, suggestion that lying people on their stomach in case they regurgitated food, or that was the rationale behind that.
That's right.
But do we know in sort of traditional cultures, what are kids? Is this sudden death an experienced in hunter-gatherer societies, in traditional cultures?
Yes.
The answer is yes?
Yeah. Now, when I say yes, that has to be a little qualified, because you can't actually call sudden infant death unless there's a full autopsy. Okay, so in many, many parts of the world, they don't do full autopsies for all sorts of reasons. It could be a developing country and the resources aren't available. For religious reasons, people aren't allowed to do autopsies. So when we have an international conference in this area, there's a lot of acceptance and talk about babies that do die suddenly in the night or in their sleep. It's not night, of course, it can happen any time in the 24-hour period. But you can't call it SIDS because there's been no autopsy done or no appropriate testing. And the guidelines these days, as I say, is much stricter than it was 30 years ago, because the idea behind this is to try to get absolutely true cases of SIDS so that they provide a good scientific model for us to try to work out. So there's rationale for all of these decisions, which is quite good, but, sometimes the devil is in the detail. So while we make a really good decision on that basis, sometimes it doesn't help on another side of the thing. But yes, it's a worldwide phenomena. But one of the things that anyone listening to this should know is one of the biggest risk factors that we have is smoking. Yeah.
Of the parent.
Of the mother, or indeed environmental cigarette.
Wow.
So the mother intaking the cigarette smoke during pregnancy and even post-pregnancy as well. So while only about 15% of mums smoke, SIDS babies, about 70% are born to smoking mums and environmental smoke. So cigarette smoking is a huge thing that we really could change.
Mm-hmm. And the other thing, you mentioned sleep apnea in kids, and I know adults are becoming more aware. They're certainly aware of snoring.
Yes, that's right.
Either voluntarily or involuntarily, they're aware of it. But the focus on obstructive sleep apnea as a serious issue for adults is something that's gaining a lot of attention. But in children, they don't escape that either, do they? What are we seeing in terms of incidence of that in children?
Well, about 2 to 4% of children will have sleep apnea. We deal mostly with infant sleep apnea, and we put little babies on CPAP. It's wonderful. In fact, that's one of the things I did do is develop a mask for infants. So it was more comfortable for them to wear. Obstructive sleep apnea in infants can be quite devastating, the effects of it. And often a child will present a failure to thrive. Sometimes they have other learning difficulties, lots of presentations. And once we get their sleep under control and we fix up their obstructive sleep apnea, they start to meet their milestones. They start to thrive. Because sleep is so important, as we've discussed in the past, not just for adults, but for children. And children, the effects of lack of sleep is more exacerbated because they can't learn, they can't grow, they don't have good muscle development. So it's so important to get children's sleep on track.
And of course, another risk factor there was upper respiratory infections, which are common. And it's interesting for me, Carmel, because we know that many children, in fact, the vast majority of children are born with narrower upper airways than they should otherwise have. And that would predispose upper airway issues. So I can only imagine this in itself is a big issue.
Yes, but don't forget, Ron, at the same time, they have to have this unknown underlying vulnerability. So yes. The vast majority, I'm talking almost every child, has an upper respiratory tract infection.
Yes.
Absolutely fine. So I don't want,
I don't want everyone panicking.
That's right. But the unusual child has a vulnerability that we don't know about. And certainly that's the theory that we're working on. And I think most researchers in the world are looking for this vulnerability. What is it that what is a marker we could possibly use to say, okay, this child is vulnerable, like, 1,000 children aren't vulnerable. This one child is vulnerable, and let's just keep this child safe through this vulnerable maturation period, whatever that is. So it is the holy grail of SIDS. And certainly by improving your risk factor, that is not having a baby face down, sleeping, that's taking away one of the major risk factors. And as we've improved the smoking rates of parents, that of course has brought down the rate of sudden infant death too, because it's taken away one of the risk factors as well. So the more we get rid of the risk factors, the better off everyone's going to be. But of course, we've still got those children that will die because of this vulnerability.
And when you talk about vulnerability, and I know we could get very technical if we got into the biochemistry of this, but are we talking about biochemical markers, genetic markers? Is that what's on the short list of your vulnerabilities?
At the moment, there's huge work being done in the genetic space, as you could imagine, and some very interesting work going on there that. I was speaking to someone the other day about it was a conference that it's not written up yet, but it's really interesting, the genetic space. I'm actually looking at, not surprisingly, the biochemical markers. So these things would work together. I would, further down the track, I'm sure. And I don't think, sometimes it's 30 years ago now, and it's been such a long and protracted journey. But sometimes I feel like it's not going to be that much longer until we unravel the mystery of this. And it will be, I think, we will probably have a genetic marker, and we might have a biochemical marker as well.
Wow.
Crossed.
Fingers crossed, because I can, the trauma of that experience, in our family, we had a stillborn between our two kids. So happening right at the last minute, literally the last week. And it's not what you expect or hope for, and it is a trauma that stays with you and makes you appreciate the wonder of the children you have that you would otherwise take for granted.
I think that's an absolute gift.
Yes.
You realise, of course, anyway, as soon as you have that beautiful baby, how much you just don't love them, you adore them. But you certainly recognise even more just how wonderful and how lucky you are to have your children that you have, and to have healthy children, really, Absolutely. The ones that you have. So I think while you would never, ever want this to happen to anyone, there are, as time goes on, there's certain gifts that are a consequence that you wouldn't have if you weren't, you didn't have to experience the trauma.
And the other thing I would say is that if you're fortunate enough to sail through every one of your pregnancies and children's lives without any hiccups, that's fine. But when it does happen to you, it's surprising how many stories emerge that you hadn't heard before.
That's right. And I have stopped judging anyone, right?
Yes.
Because you don't know the story beneath or behind. And you're quite right. I don't often share this story because it is too confronting for people oftentimes, and they like to, like things to be pretty and happy and all that sort of stuff. So you tend not to tell them the true story. Yeah. But when you do, people, as you have done, have shared a catastrophic story. So most of us have something in our life that we have to deal with on an ongoing basis, I believe. Yeah. And it does make you a different person. I don't think it makes you a better person. It makes you a different person.
Yes, absolutely. Look, the subject of sleep and, Carmel, your book, A Consistently Good Night's Sleep, is just a wonderful, that's it, isn't it? A consistently good night's sleep.
No, there's two actually. There's a sleep diet, and then
yep.
there's the second one, the complete guide to a good night's sleep.
Complete Guide to a Good Night's Sleep is a wonderful book. I know I read it many years ago when we first spoke. People are hearing this all the time, but I think it bears repeating. Why is sleep so important?
Yes, look, it's, we live in an age that people want to shortcut everything, don't they? I don't want to sleep that much because I'm not doing anything when I'm sleeping and it's really boring and I'm not getting the rest of my life lived. But unfortunately, there's no shortcut when it comes to sleep. And we sleep for about a third of our lives. Now, this is no evolutionary mistake. Evolution doesn't make mistakes. And we sleep as adults on average about 8 hours, or we should, for the simple reason that 8 hours allows us to operate at an optimal in our wakeful hours. So people don't doubt that wakefulness is basic to survival. Okay, so we've got to eat, we've got to drink, we've got to exercise, we've got to get rid of waste products, all that sort of stuff when we are awake. But when we sleep, we're actually doing other vital functions that we actually can't do when we are awake. So we get our body cleansing our brain, we're bedding down information, we're repairing and restoring our cardiovascular system, our respiratory system, we're firing up our immune system, all these sorts of things that the body doesn't have space to do when we're awake, it's doing when we are asleep. And it is fundamental, what these processes that occur in sleep are fundamental to our survival. And in fact, if you were to deprive a group of rats of food and another group of rats of sleep, the group of rats deprived of sleep would die sooner than the group of rats deprived of food. So I don't think I need to rave on anymore because that's very clear of the fundamental nature of sleep and what we do. So sleep underpins our physical good health in the short and the long term. It underpins our cognitive performance and it underpins our behaviour as well. So our good ongoing behaviour. So it underpins all of that.
Yes, no. Music to our ears here, Carmel. It's a major focus, but it's good to hear that, and that was beautifully put. One of the things that attracted me, I was looking at your work, and you mentioned Men Are from Mars, why women sleep differently to men and what we can do about it. Can you talk to us a little bit about that?
Yes, women actually have life stages, as we all know. We don't give enough importance to this. So women go through puberty, but men do, of course, as well. Then they have the pregnancy, so pre and postnatal, and they then have menopause. So at each of these life stages, it does present issues around sleep in a way it doesn't for men. Now, just for a moment, men at puberty, prior to puberty, men have an incidence of sleep apnea at the same level as, so young boys and young girls have the same level of sleep apnea, all right, same incidence. However, post-puberty, boys' vulnerability to sleep apnea increases because they get the elongation of the airway, narrowing that airway, and of course that's why they have the descent of the airway. That's why they have the deeper voice, but it makes it more vulnerable to collapse, okay, because all sorts of things happen here. So boys have that, but girls have the introduction of estrogen and progesterone. Now, progesterone is a soporific. It actually makes you want to sleep more, and you get more of that in the second half of the cycle. And what happens is in women from the age of puberty onwards and for the rest of their life actually need more sleep than men, but are unlikely to get it. So on average, they need at least 20 to 30 minutes more than men. But some women would, of course, need more than that. So as we age and we often get a partner, we might mimic their sleeping hours, which means that you're underslept. But more than that, young girls in the second half of their cycle, or fertile women in the second half of their cycle, need much more sleep than the first half of their cycle. But because we now go out to work and we've got the imperative of 9 to 5, most young women don't get the sleep they need in the second half of their cycle, that increased sleep. And of course, when we think about lack of sleep, we know that it affects our behaviour, so we become grumpy and irritable. It affects our cognitive performance, so we become foggy-headed. And it makes us more likely to get colds and flus. So if you talk about premenstrual syndrome, you're all of a sudden getting a lot of those characteristics, right? Grumpy, irritable, foggy-headed, you know, and we've always put it down to hormones, you know, this premenstrual syndrome. Yeah, and yes, it is hormonal, but to my way of thinking, and more people are recognising this, we need to really educate young women about the need to increase their sleep in the second half of their cycle, because they've got hormones that are actually making them sleepier and increasing their need for sleep. And there's a very good reason for this, because as fertile women, you might be incubating a baby. And so the body's going to protect you. So the body is really very harmonious, and we need to listen to it more. So when women didn't go out to work, they worked within the home, the second half of the cycle, they could probably snatch, you know, an extra half hour sleep during the day. But they can't do that now. And we're not recognising these biological differences. It's great to think, yeah, I want to do this and I want to do that. And right, that's fantastic. That's what you want to do. And there should be no boundary with anything that a woman wants to do. But at the same time, we have to recognise the physiology is different, and let's play to our strengths. If we want to put the best woman forward, then we need to be slept well as well, you know. Yeah, so I don't think we recognise that. But of course, also by the time, postnatally as well, there's all sorts of issues, or prenatally. By the time a woman has a baby, the last trimester of pregnancy can be very difficult in terms of sleep. And so many of these women, by the time the baby's born, are sleep deprived, and it sets them up, you know. Yeah, so you can imagine all that stuff going on. And of course, by the time a woman is perimenopausal, at that age, about 50% of women, so that's 1 in 2, report sleep issues. So yeah, men and women are different.
Yes, boy, I often reflected on that third trimester, you know, which physically, because of the size, the bulk, difficult to get comfortable, but it's kind of dismissed as, it's getting you used to having sleepless nights with your baby getting up, but that's no. Wow. Yeah, look, it's and you mentioned also that prepubescent boys and girls, have the same level of obstructive sleep apnea.
Yep.
What is that? I mean, you mentioned infants as 2 to 4% have obstructive sleep. Is that the same statistic as we go into as we're approaching puberty?
Probably more around the 2%. And of course, that can be influenced by the crowded upper airway, as you spoke about. It could also be influenced, of course, now we have an obesity problem even in our children.
Yes.
And so that's going to increase your vulnerability to obstructive sleep apnea. So, yeah, about 2%, I think.
Now, another area that's challenging from a sleep perspective is shift work.
Yes, absolutely.
So talk to us a little bit about some of the challenges there with shift work.
Well, of course, shift workers, we know, on average get at least 1 hour less than the general population, but it can be as many as 3 hours, 1 to 3 hours less. Because if you're working through the night hours, you're going against your internal biological clock. So your melatonin is your master hormone. Melatonin is not only your master hormone, but it's really important in the story of sleep, and also in the setting up of your biological rhythm. So when we're exposed to dim light, or as the sun starts to fade more generally, our brain starts to produce melatonin. And about an hour and a half after we start to produce melatonin, if we stay in the dark or the dim lighting, we'll be ready to go to sleep. Now, when we wake up in the morning and expose our body to bright light, there's an off switch of melatonin at that point. Now, it's that off switching of melatonin that sets up the biological clock for the next 24 hours. So that determines when you get hungry, when you've got the greatest cardiovascular strength, when your blood pressure is the highest and the lowest. It determines all sorts of things, this lovely biological clock. And our body loves nothing better than routine, right? And so what happens to a day worker is, okay, I go to bed at 10 o'clock, go to sleep, if we're lucky. We get up at 6. Our biological clock is set at 6 o'clock, and that is consistent day after day after day. And so everything runs like clockwork, very harmoniously. Now, compare that to the shift worker. 1 minute they're exposing their eye to bright light at 6 o'clock. The next minute they're trying to stay awake in bright light at 3 o'clock in the morning. So the body doesn't know when is my clock going to, when is my body clock going to have a routine. So this actually makes people with shift work have all sorts of an increased vulnerability to all sorts of chronic illnesses, because, as I say, the body likes nothing better than routine. So shift workers are much more likely to have mental health issues, much more likely to have gastrointestinal issues, more susceptible to certain hormonal cancers, and the list goes on, unfortunately. So shift work accounts for about 20% of our workers at the moment, and it's not going to go away anytime soon. So you think about all the healthcare workers, right?
Yes.
Yeah, and under the stress that they've been under the last year, it's just incredible the work they do. They don't get recompensed enough for what they do. No. I don't think our fabulous healthcare workers. But so shift work's not going to go away anytime soon. So we need to educate shift workers on how to make the most of the time they have. And I don't think, by and large, we do this well enough, because it is a public health issue, and we're not dealing with it well enough.
And what would you say, well, if you had to give a shift worker a few hints to say, this will get you back on some sort of track, because it's going to be a compromise?
It is a compromise. So I'll just take an example of someone who works nights. Okay, so if you're on night shift, you don't try to do so often people work night shifts, and during the day they're expected to do things. So they might have young children, and the other partner is out working. So night shift work is meant to pick the kids up from school or make the breakfast or whatever. A night shift worker can't do that. When they're on night shift, their day is their sleep. It's not time to do all this other stuff. So one of those things is actually having that adult conversation between the partners as to, okay, you're on night shift, so I can't rely on you to do anything during the day because you're meant to be sleeping. Yeah. Right? So that is a huge issue, right? I've spoken to many, many people about this, and they go, oh, but I have to pick the kids up.
Yes.
Or, no, you don't, because you're not really there. You're meant to be, this is your 2 o'clock in the morning. So the other thing is too, so if you're working night shift, you actually have your largest meal prior to the night shift. Right? So, if you're starting work at, say if you're a healthcare worker, you're starting work at 10 o'clock at night, you'd probably have your dinner at 8 o'clock, your major meal at 8 o'clock at night. Then you'd have a light lunch in the middle of your shift, and then you have a small amount of food when you get home. See, that way the worst thing you could do is have a large meal when you get home. That's just because your body's trying to digest. So you eat according to like your daytime hours, unfortunately, but you don't want to make it too late because that's going to cause some other problems. Try to have a lot of shift workers, because their day and everything's all disrupted, they have processed foods. It's easy access to processed foods, but that has been shown to be really detrimental to sleep. So whole foods are really important in the story of getting to sleep. And so if you're on night duty, so you're starting work at 10 o'clock, then if you come off shift at 6 o'clock or 8 o'clock in the morning, then you sleep for most of that day, but you might actually wake up at 2 o'clock in the afternoon or 3 o'clock. It could be hot or it could be anything. And that's fine. Get up then, do something, but then try to have a full sleep cycle prior to the start of your shift. So when I say a full sleep cycle, that's about a 90 to 110 minute sleep prior to the start of your shift. But make sure you give yourself enough time to wake up from sleep before you drive to work. And on your way home from work, try to minimise your exposure to bright light. So
including sunlight.
Oh, absolutely, yeah. Dark glasses, anything. But lots of people, think, oh, I need the sunlight to wake me up to drive home. But if you're feeling that tired, I do recommend having a 15-minute power nap or 20-minute power nap before you leave work. So people who have shift work in their environment, like people who have employed by people, the employers should provide somewhere where these people can have a 15-20-minute nap before driving home. This is especially important in remote areas where there's sort of real issues happening there, because a 20-minute power nap will just get you over the hump of tiredness. It won't affect your ability to fall asleep when you get home, but it will keep you alert enough to drive home safely.
Gosh, I mean, I just think there's been something incredibly reassuring, hasn't there, since the beginning of time, that the sun has come up every day and the sun has gone down every day, and it's played an important part in everybody's life. But to take that out of the equation, where can we play around with melatonin there? Does melatonin supplementation have a place in this shift worker?
Yeah, so melatonin is really getting lots of attention these days. And unfortunately, people are using melatonin for all sorts of things. But there's 3 situations where I think melatonin is good. Shift work is one of them, all right? And you would use it according to what's going on with your shift, all right? So people have to take advice on when best to take the melatonin if they're working shift. But yes, shift work. Jet lag can work really well. And for sight impaired people, because they don't get the sunlight sight bar that they need. And so that's, they're the 3. So by giving melatonin to sight impaired people, it helps them set up a biological clock. They of course can have one, but it does entrain them a little bit better.
Now, another issue that people face is insomnia, or we hear a lot about, and it's a word that's bandied around. You know, I've had a few bad nights' sleep, I'm suffering from insomnia. How do we define insomnia in the first place? How do we know whether we really are suffering from insomnia? What is it? How do we know?
Insomnia has a clinical definition. So it's unable to initiate or maintain sleep with the result that you don't get enough sleep. And it has a daytime consequence, like you might be fatigued all day, or you might be getting headaches. So it has a daytime consequence, and it has lasted for more than 6 months. So that's the clinical definition of insomnia. However, we will all go through, we might have acute insomnia, so something traumatic's just happened to the stock market, for example, you know, and everyone's losing their savings. So for the first couple of nights, you're not sleeping well. So that's, you know, acute insomnia. It's subsequent to a shock. And so, of course, you're not going to be able to sleep because you've got adrenaline pumping around your body. Then there's, you know, sort of short-term insomnia where, for example, you might have started a new job or a relationship breakup or whatever, and for a couple of weeks you don't sleep well. And most people go through that. The real issue is the chronic insomnia, where people over a period of 6 months or more are really having a tough time. And one of the issues with chronic insomnia is that people get so desperate to sleep that they start to implement all sorts of unusual behaviours that they think might help them with their sleep. But by the time they come to someone like me, you actually have to unravel all those behaviours because they aren't actually helpful. But it's, you know, one night it might work, it might not work. And a lot of these people actually don't want to be on medication, but if they go and see their GP, they are given medication. Now, in the short term, that's great. You know, some people need to sleep, and so if you need a prescription sleeping pill for a little bit, that's okay. The trouble is, of course, people then start using them. They go back for another script and another script and another script.
What is short term for you? How do you define short term?
Yeah, 10 to 14 days. Yeah.
10 to 14 days, because many people have been on it for months or years.
Yeah, that's right. The trouble is, of course, the efficacy is lost. The actual pharmaceutical benefit of it is lost at that stage. But many people, as you say, are on it for months or years, but without any discussion about what's going wrong with your sleep. Why do you keep needing this? So indeed, the conversation should be had, and doctors are getting better at this. Okay, look, I gave you a script a month ago for the sleep, but why do you still need it? what's going wrong with your sleep? Do we need to look more forensically at what's happening so to allow you to get a natural sleep? Because prescription or most drugs will change the structure of sleep and not for the better. Yeah.
And I'm guessing that it's interesting that you should say that, because it often surprises me how often patients come in on antidepressants or anti-anxiety, and no one has ever explored their sleep.
Right.
And it's the same kind of thing. What sort of interventions do you suggest for people who do suffer from insomnia, real insomnia?
Yeah. So sometimes insomnia, there's a couple of things. So insomnia can be for absolutely no reason whatsoever. We can't find, of course, it's primary insomnia. Now, in that case, it's quite difficult to treat. One of the things you'd like to look at is, okay, so you've got primary insomnia. So some people think they need 8 or 9 hours sleep a night or 8 hours sleep a night. But their mum, their grandmother and their grandfather, they only ever slept 4 or 5 hours, So in fact, I have had a case where a person, actually from genetic history, from family history, was a short sleeper. And they were so convinced they needed 7 hours. But in fact, by the time we were finished, she was quite happy doing the 5 or 6 hours, And so she taken the stress out of the fact I'm not getting 7 to 8 because everyone's telling me I need 7 to 8 and I'm going to have all these consequences. But in fact, she was one of the rare few that didn't need as much. So that could be it. But secondary insomnia it's obviously secondary to some other issue. So it could be secondary to a sleep disorder. It could be secondary to anxiety. It could be secondary to sleep practices, sleep behaviours. So that is much easier to treat. And so we unravel that story. We check all those indices, and by and large, secondary insomnia is something that is more common than primary insomnia.
Yeah, look, we've covered some ground here today, Carmel. I've really enjoyed our talk, and I want to have the links to your website where you've got those resources of your books and everything. I wondered if we might finish now just taking a step back from your role as a researcher, as an author, as a lecturer, because we're all on this health journey through life in this modern world. What do you think the biggest challenges are for us as individuals on that journey?
I think maybe... do you feel, sometimes I feel that people have lost the joy of life? Yeah, sometimes I look at people and they're so busy trying to get ahead in this money-dominated world. The joy of life has sort of been taken away. And maybe that was highlighted a little bit last year when all of a sudden the world changed and some of us were forced back into the home, back into, what is really important here. And that was a bit of an eye-opener for some. For others, of course, it was such a stressful period. They lost their income. They could have lost their home. So really, really shocking. But I think one of the issues is that if we have the priority about life should be problems and traumatic events, which happen to all of us, there should be a level of joy and happiness in life. And if that's missing, that then affects our health and our wellness and all those things. So I think really we need to come back to basics. What can I do to increase my level of contentment? It doesn't have to be joyous, it doesn't have to be happy, but my level of contentment. And with that comes all other things, I think. So while we can concentrate on how we exercise, how we, feed ourselves and how we sleep, maybe we start to have that journey via, well, how content am I with what's happening in my life? Yeah.
Well, that's a great note to finish on, Carmel, and thank you so much for joining us today. I've really enjoyed it.
Thank you very much, Ron. Thanks.
Well, I've been looking forward to talking to Carmel for some time, and of course, sleep is, as any regular listener to this podcast will know, is a theme that we have touched on before and we will touch on again. And I'm unapologetic about it, really, because we need constant reminders in our lives that sleep is, without a doubt, the most important part of the day. Now, I'll have links to Carmel's Sleep for Health website. She's got a terrific book, The Complete Guide to a Good Night's Sleep, and The Sleep Diet, which are two wonderful books that are well worth reading. And of course, her story about her own experience with her 2-year-old son who died from SIDS or SIDS-like condition, is a story that you can follow also, and we'll have links to it. It's called Damien's Legacy, which is a story about the research that Carmel is doing at Westmead Hospital. Quite sobering, really, to think that 3 children a week die of this sudden unexplained death syndrome, and yet funding for this is difficult to find. Just to put that in perspective, 1 woman a week dies from domestic violence, and this has gained a lot of attention, quite rightly so, and should be getting a lot of funding to deal with these issues of domestic violence. That's 1 death a week. And with these 3 deaths a week, I mean, it's an incredibly traumatic experience that, as Carmel has said, you just don't get over. The hole in your life may become smaller, but it's always there. And it does change your life forever. Look, don't forget to leave a review. This is the commercial part of this podcast. Don't forget to go onto iTunes and leave a review. We want to get the ratings up there. Don't forget to download Unstressed with Dr. Ron Ehrlich app. You have to put in Unstressed with Dr. Ron Ehrlich in the App Store, and that will keep you informed of the latest episodes, which are coming thick and fast this year. We've got some great things planned, and that'll keep you up to date with all of that. So until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.